Hello everyone, I am Dr. Bagirath. I am a senior consultant cardiologist and program director of the Heart Transplant program at Narayana Health City, Bangalore. I have with me my colleague Dr. Neha Chaturvedi, and on the occasion of World Heart Day, we thought that we'll discuss about a few common questions on heart failure. Over to you, Dr. Neha.
Okay, so doctor, first tell me what is heart failure?
Heart failure is a condition where the heart is unable to pump blood at a rate that matches the requirement of the body. So basically, it means that the heart, which usually pumps at about 5 liters per minute, in patients with heart failure, it pumps at about 1.2, 1.3 liters, which is grossly insufficient to meet the demands of the patient as well as the demands of the organs of the patient.
Okay, so and what are the common causes for heart failure?
So basically we have different causes for adults and different causes for children. So in children it's predominantly storage disorders which end up in heart failure. But to be more contemporary, let's discuss about the causes in adults. In adults, the top three, that is diabetes, hypertension and high cholesterol, these translate into heart failure over a period of time. The commonest cause, I would say, in India is fast because of becoming the ischemic heart disease, and that's because higher cholesterol levels, dyslipidemia translates into heart attacks, and the damaged heart causes a decrease in the heart function, and these patients end up with heart failure. Apart from that, there are numerous other causes. There can be familial causes like dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy in a burnt out phase, which ends up in heart failure, and so on.
Okay, so doctor, this is a really good information for everyone. And now, can you please tell me how to diagnose heart failure?
Yeah. So basically, the patient comes with symptoms of breathlessness, exhaustion, and there is waterlogging all over the body. There's swelling of feet, distension of abdomen, puffiness of face, profoundly breathless, sweating. So this is enough indication to say that we need to assess on the lines of heart failure. Now, when you want to diagnose heart failure, we start with the common investigations like the ECG, chest X-ray. The cornerstone of diagnosis, of course, is an echocardiogram, and in echocardiogram, you have multiple specialized forms of an echo like 3D rendition, wherein you can actually look at the three-dimensional view of the heart. We can assess the ejection fraction of the heart, which is a common number to go by to decide who has heart failure and who doesn't. Apart from that, you have the speckle tracking, you have various other modalities where segmental analysis are possible. So echo is a big cornerstone in the diagnosis of heart failure. Apart from that, we have more advanced ways in which we can diagnose heart failure, like CT scan, we can do an MRI, we can do perfusion scan imaging. Of course, I must say that all patients, as a protocol, we do both a CT angiogram and, if necessary, a coronary angiogram. This is to identify whether ischemic heart disease is the reason for heart failure. So in all, you have a big gamut of tests to diagnose heart failure. Notwithstanding, we have to run off multiple blood tests to identify whether the patient is diabetic or dyslipidemic or any other contributory causes for heart failure, and work on those lines to see whether we can salvage the existing heart or move into more advanced forms of treatment where we'll have to look at either supporting the heart or even replacing the heart.
Okay, so doctor, how to treat heart failure?
Okay, so basically there is management of symptoms and also there is management of the cause of heart failure. So symptoms, of course, any patient who comes with heart failure, the first thing is to help him to breathe better, to get rid of the excess fluid. So on these lines, we generally treat them with inotropic support, which is a medicine that will help to improve the heart pumping, albeit on a temporary measure. We also give these patients medicines to remove the extra fluid. These are called as diuretics. So initially we start with injectables and then graduate into tablets. Apart from that, you have the common 4 pillars of heart failure management. This is the beta blockers, you have the angiotensin receptor blocker or ACE inhibitors, you have the ARNI, which is sacubitril with valsartan, and you have spironolactone, which is one of the pillars of heart failure management, and of course the latest kid on the block, that is the SGLT2 inhibitors. So these are all the medicines which have to be given for patients to manage heart failure. So this much about the medical management. Of course, supportive medicines are always required. You'll have to manage concurrently diabetes, you'll have to manage hypertension, you'll have to manage dyslipidemia, and all the other problems like a low hemoglobin and so on, which the patient may have. Apart from this, you have more advanced ways in which you can treat heart failure. So this is a big therapy by itself. One is the device therapy. We have specialized form of pacemakers which can be used for management of heart failure. The CRTD, or the cardiac contractility modulation, or in some patients who don't have bundle branch blocks, we just put them on an ICD or an internal cardioverter defibrillator, which will help to save precious lives. We also have other forms of treatment like ventricular assist devices. A left ventricular assist device is the commonest. We also have biventricular device, and we have total artificial heart, which takes over the function of the heart completely. So much said about the mechanical circulatory support of the heart. Apart from this, of course, we have the eternal heart transplant program. Here, we replace the patient's heart with another suitable donor's heart, and this takes over the function and helps them to lead a very high quality life, and above all, live with dignity.
Okay, so doctor, after this, I have one question. Who needs heart transplant surgery, and what are the outcomes after heart transplant surgery?
Okay, so who needs a heart transplant? Well, as I've said already, the first endeavor would be to manage the heart failure and improve the existing function, improve the existing heart's function, so that we can avoid a heart transplant. Nobody wants a heart transplant, but in some instances where you've tried all the medicines, you've tried most of the devices available, and yet the patient is still symptomatic. At times we call this refractory or end stage heart failure, wherein you've been there, you've done that, you've given every possible medicine, every measure has been tried, but the patient is not improving, continues to be symptomatic. And if you see the longevity of the patient, it's likely to be very short-lived, because the patient will not be able to survive even 1 year with this form of treatment. So at this time, we introduce the concept of heart transplant to the patient. So these are patients wherein we work them up completely to see if they are, first of all, suitable to undergo a heart transplant. The common tests that we do are right heart cath study. Here we see the pulmonary artery pressures to see whether there is an increase in the lung pressures, because this often becomes a stumbling block, and we may have to do a heart and a lung transplant rather than just a heart transplant alone. So if the lung pressures are suitable, then we look at various other parameters, particularly the pulmonary vascular resistance, the transpulmonary gradient, and so on. So these are measures which tell us whether the patient is suitable. Once we assess that the patient is suitable for a heart transplant, then he is listed with the Jiva Sarthakate, which is the apex body of the government for a heart transplant, and then he officially gets onto the waiting list of a transplant. Yes, so once the patient is on a heart transplant list, then approximately the timelines are usually a couple of months. And when we get a suitable donor which matches the blood group of the patient as well as the body size of the patient, then further studies are undertaken to see the suitability for a match, and then we go ahead for a heart transplant.
Okay, so doctor, this is really helpful. And now, can you please tell me, are there any other options other than heart transplant surgery?
Yes. So these can be looked at from two different points of view. Number one is that we would like to try these measures before we embark on the journey of heart transplant. And at times there are patients who are very clear that they don't want a heart transplant. So in both these instances, we will have to look at other options. As I've said, the starting point would be to look at pacemaker-based devices. The CRTD, which I just mentioned earlier, is a cardiac resynchronization therapy device. So this essentially is a triple chamber pacemaker which has 3 leads, and this will help to improve the heart's pumping. Again, this is if you look at 100 patients, they are divided into 3 different responders. Let's say 1/3 of them are likely to get a full recovery of the heart function. The next one third are likely to get a partial recovery, and of course the last one third are the unfortunate ones who will not recover or actually have a deterioration over time. However, it remains to be one of the best promising options. Apart from this, you have cardiac contractility modulation, or a CCM device. The CCM device can be charged percutaneously, and this helps to improve patients who do not have a bundle branch block but yet require pacemaker form of therapy. Yes, apart from this, you also have the assist devices, particularly the ventricular assist device. In ventricular assist device, you have the intermediate device and the permanent devices. So the intermediate devices are those wherein the patient would require a support for approximately a week, or maybe even just a little bit longer than that. Whereas the permanent devices are those devices which are implanted into the patient, and the patient will continue to live. This is called as destination therapy, wherein the patient has to continue to live with the ventricular assist device almost as long as life permits. So the destination therapy, or the destination devices, have come of age now. You have excellent devices. The charging is once in 11 hours. And the patient has an extremely good quality life. You have even Olympics for these patients because they are extremely active, they are physically fit, and they are totally mobile. Of course, there is the problem of replacing the batteries every 11 hours. You have, just like a mobile phone, you will have to replace it with charged batteries, and then life goes on. They can also be connected to the power lines if the patient is going to be seated in his office, or you even have adapters when the patient is driving, so that the device can be charged. So these are called as ventricular assist devices. Now some patients, the ventricular assist devices are predominantly for left ventricular failure. So supposing the patient has failure of the right ventricle also, then you have biventricular devices. So this is the same device which is available for both the ventricles. That is, you have a right ventricular support and a left ventricular support. Apart from this, you also have a total artificial heart, which is you replace the entire heart with a device. The beauty of this device is that it is completely implantable. It gets into the pericardium and it does the function of the heart. It has bioprosthetic valves which function as the normal patient's heart. Of course, you will have charging cables and so on. So you have excellent devices, miniature devices now with excellent cardiac output facility. They can give even 10 liters of cardiac output, what an Olympic champion would have. So the patient is absolutely physically fit, and above all able to move around with dignity. He doesn't have to depend on anyone and has a very good quality life. Apart from this, you also have temporary support devices which are available. So these will help to support the patient for varying lengths of time, so that if the patient's own heart recovers, very good. If it doesn't recover, and despite all this you still have a failing heart, then of course, yes, you'll have to look at heart transplant. So I think we had a very fruitful though basic discussion on heart failure management and also the nuances of heart transplant. Thanks, Dr. Neha. You've brought out in this small discussion some important questions that patients keep asking me regarding heart failure and heart transplant. I hope this message gets across that heart transplant is a viable option, and we have multiple options today for heart failure patients. And also heart transplant is very much possible. At our institute, we've done more than 90 patients ranging of varying ages, and all of them are leading a very, very fruitful life. So the message to all of you is that heart failure is immensely treatable. Heart transplant is definitely an affordable option for heart failure. And of course, we are in this journey with all of you to help you to lead a very fruitful, very active life, above all, a life with dignity. Thank you very much for your attention.
Thank you so much, Doctor. Actually, this is a really great discussion about heart failure and heart transplant surgery. I hope this discussion will help people out there. Thank you so much.
Thank you very much.